Okay, let's talk about scaphoid fractures. Scaphoid fracture, a lot of people just say wrist fracture. Yes, you can definitely fracture other bones in the wrist. But I would say because of the area, kind of the location of the scaphoid, and the idea that there's likely more complications with the scaphoid, we're really just going to focus on scaphoid fractures as our wrist fracture. Keep in mind that the scaphoid fracture obviously is different than a distal radius fracture. We are separating these two things out. So when people say wrist fracture, again, this could be scaphoid, this could be other carpal bones, or this could be distal radius. It could be any of those three things. So just keep that in mind. So here's our picture of our anatomy to remind ourselves, because we all struggle with the carpal bones, right? So the scaphoid you'll see here is number 2 in the x-ray, and it's red on the picture on the left. The scaphoid articulates, so it's affected by the radius. So you see how it definitely has a large surface area articulating with the radius. It also articulates with the lunate, which is number 3, and the trapezium and the trapezoid, which are number 9 and 10. So all of those bones are going to be affected on some level when we have a scaphoid fracture. So the big thing to keep in mind is that there is a good amount of cartilage, around 80%. Articular cartilage covers 80% of the bone itself. But the primary blood supply is coming from the radial artery through the posterior ridge of the middle of the bone. So you can see there's a picture here on the left that shows the radial artery and how the artery kind of has 2 different branches that go off and will send blood flow to the scaphoid. That doesn't seem to be terribly important. We don't usually talk about this kind of stuff, but the problem is the way that blood flow occurs, we call it kind of a retrograde pattern. The way that blood flow occurs with these 2 different areas, 2 different branches, the dorsal branch and the volar branch, the fact that is the blood flow anatomy of the scaphoid means that if we have a fracture in certain parts of the scaphoid itself, we're much more likely to have a non-union. So we're much more likely to have issues with the bone not healing and not healing together. So if you look at the blood flow there, the proximal part, so kind of the bottom of that picture, has the least amount of blood flow. So if the fracture happens where the bone is articulating with the radius, you're less likely to have good outcomes. You're more likely to have non-union. You're more likely to have some sort of avascular necrosis that can happen with that bone. So 4% of all fractures are a scaphoid fracture. Again, most of the time when people say they have a wrist fracture, that's probably what they're saying. They broke their wrist, it's probably what it is. It's the most common carpal bone, so 70% of all carpal fractures are going to be a scaphoid fracture. For some reason, men tend to have this one more. I don't think we really know why, but it's usually because of either that fall on the hand, so that's the most likely problem, and it's usually if the wrist is hyperextended, so it's past 90 degrees or 95 degrees, so they're really getting a lot of extension of the hand, then they're more likely to, or more extension of the wrist, they're more likely to get a scaphoid fracture or a compression injury. So the compression injury, maybe that's why men have more of them, because men are doing more physical labor, so they're more likely to get compression injuries during physical labor. I don't know, that's just a thought. Usually happens in young people. Like I said, it's the most common carpal bone to fracture, and it happens in athletes. So gymnasts who fall, divers who are pushing off of a board, badminton, cricket players, all of those guys are most likely to fracture their wrist, and they're most likely to fracture their scaphoid. And what's good is that the distal pole of the scaphoid is most often affected. So if you remember back to that picture we looked at before, the blood flow to the distal pole is usually pretty good. It's that proximal part that doesn't have great blood flow. So that's good because that means we're probably going to get relatively good outcomes and good healing. What's interesting about diagnosis is that x-rays do not find scaphoid fractures that well. Only 65 to 85% of the time are we going to find this one on an x-ray. So again, a lot of the time we can say, oh yeah, just go get an x-ray and you're fine. Scaphoid fractures can get missed. You can see 1/3 of the time they could get missed. An MRI, however, is very sensitive, 96% sensitive. So as we talked about before in the West, we don't use MRI. We try not to use it too much. It's very expensive. But in Shanghai, or in China in general, would be highly recommended. If you're not sure, I'm gonna show you this scaphoid score thing. If you are in a clinical setting, I would suggest you do this clinical scaphoid score test. And if you think it's positive, send them to an x-ray. Send them to an MRI immediately. It's worth it to get these people, to get them into an MRI to confirm if there's a fracture or not. So what is the clinical scaphoid score? This is a group of tests that you want to do all the tests, okay? And each test there's 3 tests. Each one has a different number of points. So if you put your finger in what's called the anatomical snuff box of the wrist with ulnar deviation and there's tenderness, then that's 3 points. So if you look at that top picture, you can see that the anatomical snuff box is this hole, essentially. You come down from the thumb and you find the extensor pollicis longus and the abductor pollicis brevis and longus, and you go in between them, and there's a little hole. And so if you put the patient into ulnar deviation, so you're putting that area kind of on stretch a little bit, and you palpate in there, and if they say, oh yeah, that's tender, there's the definite possibility of a scaphoid fracture, and so that one gets 3 points. The next thing you do is you turn the hand over, and you palpate what's called the scaphoid tubercle. So the scaphoid tubercle, again, that's the second picture down. You kind of come down from the thumb, and where the thenar eminence kind of ends, underneath there is a little bump. That right there is called the scaphoid tubercle. And if that is tender, then that gets 2 points. And then the last thing you do is you give compression to the thumb. So you basically take the thumb, that's the bottom picture there, and you push the thumb towards the scaphoid. And with that compression, if there's pain, then you get 1 point. So basically, if there's a score of greater than 4, meaning at least 2 of these are positive, and the top one definitely is positive, then if the score is less than 4, so if the top one's not positive, but the other 2 are positive, or just one of the other ones is positive, then there's 96% likely that it is not a scaphoid fracture, okay? So that's why these tests are nice to know. If you have a patient who just has some wrist pain, you're not sure if it's a fracture, you're not sure if you send them to an MRI, do this clinical scaphoid score. Do these 3 tests, and if the score is less than 4, you probably don't need to send them for an MRI. It's probably some ligament sprain, mobility deficit problem, Decker-Vein's tenosynovitis of the thumb, something else. This is a really cool looking image of the scaphoid, and I just kind of put this in here so that you can see kind of where that basically that halfway mark is where the blood flow changes, and so you want to make sure you kind of know where the blood flow is, because the above that area has its own blood flow from the area below. And so if there's a fracture somewhere that can affect the blood flow from one to the other, that's where the fracture is most likely to occur. So again, this picture kind of gives you an idea of where you don't want a fracture. And you don't have to know this necessarily. The surgeons are the ones who know this, but when we're talking about complications, you're going to maybe want to look back on an x-ray and say, okay, wait, where was the fracture, and is the blood flow an issue at this point? So most of these patients are not going to need surgery, okay? Most of these patients, 60 to 70% of them are stable. They're non-displaced, meaning there's no gapping, there's no shifting in the bone. And so they're going to immobilize them, usually with a cast. So this is not where a brace is used. Usually they're going to put them in a cast for 10 weeks. And this cast is not going to allow for movement of the thumb. It's going to allow for movement of the fingers, however. And so you're going to basically, while they're in the cast, you're going to be moving the fingers a lot. You're going to be moving the elbow a lot. You're going to be doing all those things. So you can definitely do isometric exercises, biceps, triceps, deltoid, rotator cuff, all that stuff. Once the cast is removed, then you start doing a huge amount of range of motion. Okay, so active range of motion, really, really important at the wrist. After they remove the cast, they may be wearing a brace. So if they're wearing a brace, that's fine. Just take it off, and then have them move around. Elbow movement is fine during this period as long as they're staying in a neutral supination pronation position, right? So remember, supination pronation, it's not just spinning of the radial head at the elbow, it's moving the radius and the ulna at the wrist. And that is not a good idea during these first 10 weeks. So you need to make sure they understand that they should be in a neutral position, but they can certainly do elbow flexion and extension. That part's fine. So if there's not a good union of the scaphoid, so if there's shifting of the bones, then they're going to do surgery. So if it's unstable, also if the fracture line is more, let's see, this is hard to understand, distal to the apex of the scaphoid dorsal ridge. So I think that would mean where that little arrow is on the left. So in that little area of the scaphoid, I guess that area, again, may have bad blood flow, so they need to do surgery. And then the other reason they may do surgery is if they need to get back to work quickly. So they want to get it stabilized more quickly so they're not stuck in a cast for 10 weeks, like we said, which is the non-operative option. So the technique is dependent on the fracture pattern. So again, there's lots of different ways that this can fracture. It's going to basically then decide how they put in that pin. And it's usually just a screw or a pin. And they're either going to put it in from the front angle or the back angle, so either dorsally or volarly. They may have to do a bone graft. So again, if there was some sort of necrosis already or a non-union and parts of the scaphoid have lost blood flow, this is a complication and a problem, then they may have to do a bone graft. They may even get rid of certain parts. So if you remember, we talked about the proximal, if there's a fracture of the proximal part and there's a non-union of the proximal part, where it articulates with the radius, they may actually just get rid of it because it's dead bone at this point. And then if it's really, really bad and the bone never did heal, they may have to do an arthrodesis of the wrist. So they may have to fuse they may have to do fusion of parts of the wrist if the non-union is significant. So unfortunately, non-unions are somewhat common. 30% of pediatric fractures and other ones that, you could get non-union. So it's definitely a possibility as a complication that if you're seeing these patients and there's a lot of pain still and they're not willing to sort of do the mobility that they need, you might consider non-union. I already mentioned avascular necrosis being a problem. Complex regional pain syndrome, also a problem, can be a problem with distal radial fractures as well. And we don't have time to go into that, but complex regional pain syndrome, I think in China you guys call it like shoulder hand syndrome. And it's essentially this hypersensitivity of the hand that happens with trauma. It's kind of common with patients after stroke. It can be common, again, with any type of trauma. So this is trauma to the hand that somehow caused the brain to kind of overreact. And so you have this hypersensitivity that can cause like increased swelling, changes in temperature, changes in like sweating to the hand. And again, just very, very hypersensitive. So if you're seeing weird stuff like that, the patient may have this complex regional pain syndrome, something to consider. If they have malunion, what they say is to do ultrasound. So the ultrasound treatment, there is some good research from the last couple of years to show that low intensity pulsed ultrasound, because that bone is so close to the skin, so the ultrasound can definitely get to it. 20 minutes per day can actually help to stimulate bone growth. Okay, so that's good. Unfortunately, arthritis is another issue if the fracture is not healing correctly, because again, there's a lot of cartilage around that scaphoid bone, and so that cartilage can get arthritis. So that's another complication of this particular fracture and surgery. In 2018, there was a pretty good study about wrist immobilization. So this was 123 subjects. They were immobilized for two different kinds of fractures. So distal radius fracture and scaphoid fracture separately, okay? So they had one or the other. And what they found was an interesting complication was shoulder pain. And they found that if they were immobilized for too long, that they actually ended up with increased shoulder pain. So they found that these patients, if they weren't using their wrist and hand, and they were basically staying immobilized and told not to move their arm at all, that for some reason the rotator cuff tendons got irritable. And so the authors suggest that following either the distal radius or the scaphoid fracture, really focusing on exercises related to the shoulder. So doing range of motion, isometrics, things that we can do for the shoulder can help decrease the possibility of any type of shoulder irritability or shoulder injury, which I know sounds weird. It's like, well, this is a wrist problem. Yeah, well, people stop moving everything, right? That whole arm stops moving. So you really want to consider the fact that you need to think about getting that shoulder moving and keep it moving, doing some strengthening, all those things during the first couple phases when they're immobilized. So that first phase is going to be week 0 to 3. And during this phase, they probably are going to be immobilized for a period of time. And so again, shoulder stuff. Our big goal is to prevent edema and keep them moving as much as possible. So we want them to elevate that arm so that we don't get edema, because hand edema, there might be a connection between that and that complex regional pain syndrome. So we need to keep that in mind. And then we need to make sure they're limiting supination and pronation. So again, these are things that we don't think about that much, can be related to the wrist, but supination and pronation moves that radius, that distal radius, a lot. And so that distal radius articulates with the scaphoid. That can be a problem. So our treatment is working on posture and shoulder, like I said, shoulder isometrics. You can do elbow isometrics, so deltoid, triceps, shoulder isometrics being deltoid, rotator cuff, and then elbow, biceps, and triceps. You can do lots of things with the finger, just not the thumb, okay? So remember, the thumb, the trapezium, and the trapezoid both articulate with the scaphoid. So we have to be careful that we're not moving the thumb too much. But we're not moving the thumb at all, really, but we're moving the other fingers, the elbow, the shoulder. And then one of the interesting things that they have really found as helpful is mirror therapy. So there's great evidence for pain control using mirror therapy. There's great evidence to decrease the possibility of complex regional pain syndrome. For mirror therapy can be really, really helpful for a lot of things. And unfortunately, these patients, especially if they're older, they're going to be fearful about moving their wrist and hand. And so mirror therapy can be really helpful. So mirror therapy in this case, so this is not true for all techniques for mirror therapy, but in this case, they are just moving their uninvolved side and thinking about their involved side, but they are not doing it, okay? So they are doing active range of motion on their uninvolved side and looking in a mirror that reflects to look like they're moving their involved side. But in fact, their involved side, their fracture side, is not moving, okay? So in this case, you can do any movement you want because we're using the uninvolved side. So you can move the wrist, flexion, extension, ulnar radial deviation. You can move the thumb, all of those things. But again, you're not moving the involved side. So this is a great treatment. There's some great research to show that this can ultimately be really helpful with getting the involved side moving eventually. The suggestion is to do this 2 to 3 times a day for 5 to 10 minutes. I have a lot of information about mirror therapy, so if that's something that you're interested in, you guys can certainly try to contact me through Fortnace, through the leaders of this class, and I can certainly share that with you. So our goal to get out of the first phase, those first 3 weeks, is no pain with exercises. That's it. We move into progressive loading strengthening phase, which starts at about week 4 to 7. Usually the cast, if they're wearing a cast, the cast is removed, at 6 weeks. So they're going to be somehow immobilized for the first 4 to 6 weeks. Again, this is really dependent on the doctor. It's dependent on how frequently they get an x-ray. So hopefully by 6 weeks, they're out of that cast and we can start moving. The only movement that we have to be, there's 2 different movements that we have to be careful with. Wrist extension can actually cause the more pressure essentially on the scaphoid. So we don't need to push them too much into wrist extension, especially like weight-bearing wrist extension, right? So if they're just doing active wrist extension, they're probably fine. But we don't want them going into too much overpressure with wrist extension. Flexion, no problem. We also have to be somewhat careful with supination and pronation. Again, end range supination, pronation, but range of motion, just moving it through a range, totally fine. So keep up the exercises from the first phase. Once they're out of the cast, we're just doing gentle range of motion. So pictures are here: flexion, extension, ulnar radial deviation, supination, pronation. All of those motions are fine. You just don't want to push end range extension, supination, or pronation. And I would even say don't push radial deviation either, because that's obviously putting some compression on the scaphoid. You're also going to start doing a bunch of stuff with the thumb. So you can see pictures here of what we call opposition. So you want flexion, extension, abduction, adduction, and opposition of the thumb. That's treatment. Not terribly exciting for phase 2. And then phase 3 will start at about 8 weeks, maybe 9 weeks. Again, you may not see them until they're out of the cast. If that's true, I would highly suggest looking at the shoulder, make sure the shoulder's okay, making sure the elbow range of motion is good, and then doing the range of motion like we said for phase 2, so that by phase 3, they can do pretty much full range of motion. So they may be using a splint if the doctor is concerned about them doing too much motion or concerned about the surgical site. They may be wearing a splint periodically. This is when there may be some issues with non-union, and if that's true, they may end up doing that low-intensity pulsed ultrasound. They also may have to do bone grafting. So again, this complication of avascular necrosis or a non-union, they may end up having to go in and do that. And so that's something that, again, if they're not healing well or if you're having a lot of complications by the 3rd phase, by 12 weeks or so, then they may have to go in for another surgery. And that, unfortunately, is somewhat common. But if they're doing well, we can definitely keep doing range of motion. So we keep doing active range of motion, and by 10 weeks, we can start doing resisted grip and progressive resisted exercises of the wrist. So TheraBand stuff, here's some pictures, some TheraBand things. This is supination and pronation resisted. Resisted things where you're holding on to the end of a weight or the end of a water bottle or something, works really well as well. And then you'll see we can start playing with like weight bearing into the hand. So that's some of the weight bearing stuff that we can start doing in phase 3. So milestones to get you to phase 4. This milestones, basically, you want to have 20 kilograms grip strength, which is not a lot, but it's definitely some grip strength, and then 4.5 kilograms of pinch strength. So again, that thumb to finger strength needs to be 4.5 kilograms, and they should be able to open a plastic bottle, so a water bottle they should be able to do. So you test the strength with a dynamometer. Hopefully you have one. I think it's very helpful to have one. So again, 20 kilograms is not like, I don't know. I don't know how to explain it. It's not 100%. Let's just put it that way. It's probably somewhere between 50 and 80% for your grip strength. So it should be fine. But I think, honestly, that functional idea of being able to be able to twist and open a bottle is probably a better test of their strength anyways. So at phase 4, we're getting to that return to sport phase, and we want to make sure that they show on an x-ray that they have a full union of the bone. So clinically, a doctor can look at an x-ray and say, yes, the bone is completely healed and it's lined up and it looks good. They also should have pain-free range of motion within 10 degrees of the other side. So range of motion, you're measuring wrist flexion, extension, ulnar deviation, radial deviation. You're testing supination and pronation, and you're testing thumb range of motion. All of those should be pain-free within 10 degrees of the other side. Your grip strength should also be within 10% of the other side. So that's going to probably be more than what we measured in kilograms for phase 3. So you want to be testing grip using a dynamometer if you have it, and if they're within 10%, you can get back to sport. If it's a non-displaced fracture, they really can go back at 6 weeks, which seems early, But if it's just a really basic fracture, they can start going back pretty early. If it's a displaced fracture, though, that's a totally different ballgame. You'll see it's 5 to 6 months. So they're going to be, it's really, really dependent on how well that fracture is healing. So x-rays for this group is important. And maybe, x-rays, because you can't do an MRI if there's hardware, right? I don't think so. Oh, I guess you can. Yeah, you can. Oh, no, you can't. No, you can't. Oh, man, that's bad that I don't remember. Okay, and then the last little suggestion with racket sports, you're going to want to do your forehand strokes before your backhand strokes, which makes sense because we talked about extension. You don't want to put too much strain and wrist extension initially, but forehand strokes is going to be more wrist flexion control and wrist flexion power. So keep that in mind. You want to make sure that you're starting off with those more flexion focused activities before you get into resisted extension activities.